So, good afternoon to everyone. We have now the lecture of Professor Stephen D. Wexner. He will be joined within a minute. And he is one of the renowned surgeons from the Cleveland Clinic, Florida. He is the head of the department. And he is the president of American College of Colorectal Surgery. He is today talking about the fecal incontinence. He will show the video how to manage the fecal incontinence. You know, fecal incontinence is a big problem, even in the gynae, even in the surgery. This problem happens due to the perineal tear, due to the endometriosis surgery, due to the, the colorectal surgery. And this is a big problem in the almost all the surgical rectal surgery. It can happen. So today he will show you demonstrate you the videos how to perform this surgery. So he is just about to join. It's already 5 o'clock. So within any second he can join. So hello, Prof.
Hello.
Hello. Good morning. How are you?
Good, thanks. How are you?
Thank you very much. So you can start now. Share your screen
Yes, all ready to start. I'm just looking for the optimize
video.
Video thing, but I think maybe I start the video first and let's say share. I'm going to show a couple of videos relating to fecal incontinence to kind of follow up what we started last month. So I'm going to start with simple. I'm going to start with sphincter repair. You're able to see that okay?
Yes, it's fine. We can see.
This 29-year-old female sustained an anal sphincter laceration 6 months prior to this repair. The laceration occurred during a vacuum extraction of an 8-pound baby. She subsequently developed incontinence with an incontinence score of 12 of a maximum of 20. Ultrasound revealed this 120-degree anteriorly based defect in the external anal sphincter. The patient is in the prone jackknife position, so the coccyx is up and the vagina is down towards the bottom of the screen. The fistula probe has demonstrated an anovaginal fistula. The patient had been complaining for the entire 6 months of the passage of gas and stool from the vagina. What is shown is a very attenuated anovaginal septum with no palpable muscle, a patulous anus, as well as the anovaginal fistula from the dentate line. The patient is prone jackknife, so on the left side we're currently infiltrating a solution of 0.5% xylocaine, 0.25% bupivacaine, and 1 to 400,000 units of epinephrine. An anterolateral circumanal incision is made over approximately 120 degrees using diathermy dissection. You can see again the patulous anus. You can see the edema induced by the local anesthetic, which is quite helpful in facilitating the dissection. Alice clamps are placed on both the anoderm and vaginal aspect to help separate those two areas, and then the dissection will again continue with diathermy. As can be seen, the edema helps the plane separate. The dissection precedes cephalad. It's important to dissect as cephalad as possible, certainly above any scar. Periodically here, we're palpating through the vaginal aspect to ensure that no injury occurs in the vaginal aspect. In addition, a finger will be placed in the anus again to ensure that we don't make any injury on the posterior wall either during this dissection. Now, by definition, there is a hole into the vagina and one into the anorectum because of the fistula, but we're going to try avoiding making another hole. It's easiest to have the dissection commence laterally in ischiorectal fat, as is the case here on the left-hand side, and then proceed medially. And the reason for that is there's more scar medially. Here what we're showing is grasping the divided edge of the external anal sphincter. You can see it's retracted all the way towards the right. Once that muscle edge is grasped, we can better define and delineate what will need to be overlapped. What we're showing here is the separated internal sphincter. You can see the little V-shape configuration where the internal sphincter halves are separated. We're now in the intersphincteric plane on the right side, dissecting the external sphincter and the scarred edge, which is right at the diathermy point now. There's the scarred edge just below the diathermy within the Alice clamps. We're separating out the external sphincter edge, the right-hand side of the sphincter, and we'll go back slightly further posteriorly into nice areolar tissue, again, with the contralateral non-dominant index finger in the anus to prevent any type of injury to the anus or rectum. We've now mobilized the right side of the divided external anal sphincter and will commence the identical procedure on the left, again, beginning in the ischiorrectal fossa. So you can see we're dividing fat, not muscle. We'll then continue along the posterior wall of the vagina. And once that's done, ultimately, we'll do what we're now doing again, get into the intersphincteric plane. We'll grasp the divided internal anal sphincter, as is the case here, from the patient's left-hand side, dissect slightly more cephalad, again, nice, soft, areolar, supple, healthy tissue. Once the dissection's been completed and we've delineated the divided injured external sphincter, we've identified the internal sphincter, we're now excising the vaginal side. So we're excising the fistula, that is chronically infected tract of tissue, being excised, after which we will imbricate the vaginal aspect with a series of interrupted vicral sutures. So here we're imbricating the vagina. It's important not to make the vagina too tight, obviously, but nonetheless to close a defect that is that substantial in size. You can see here, once the vaginal defect is closed, we're going to imbricate more cephalad on the vagina, and that will merge with the puborectalis. So ultimately, we'll also imbricate the puborectalis muscle. Here you can see that already we've repaired the defect on the vagina, plicated the back of the vagina, and now you can see those cephalad-most sutures are going to head up into the puborectalis. We'll be able to feel that by rectal examination, but it's also important to feel by vaginal examination that we're not just grasping the back of the vagina. Once the vaginal aspect's been repaired, we'll look at overlapping the external anal sphincter, but before that is done, we have to decide whether to repair this little fistula or to excise it. In this case, we're going to excise the fistula as it's rather caudad, and here what we're doing is imbricating the internal anal sphincter first. This layer will allow the anus to become much more snug and adds another layer to the repair. So you can see that we're going to excise or trim off the infected aspect of the fistula distally on the anal end. Again, one could instead perform a core out and closure or a flap closure, but given the very distal nature and the tissue redundancy that we're seeing here, it seemed to make more sense in this instance to excise the fistula. So here the fistula is being excised. You can see the entire fistula is being removed, and we'll then need to do a little cosmetic surgery to try and optimize the appearance of the distal anal canal and the anoderm. So using a few vicral sutures, we're going to repair that area. Again, there's no fistula left, there's no granulation tissue, that has all been removed and sent to the pathologist along with the vaginal aspect. So you can see before we even commence the external anal sphincter overlap, we've already placed 4 different layers of a repair: anal mucosa, vaginal mucosa, internal anal sphincter, and posterior vaginal wall, as well as 2 sutures in the puborectalis at the apex. So there's multiple layers before the actual overlap itself. Once we are happy with the closure on the anal end, we will ultimately overlap the external anal sphincter, and we're deciding here whether the best configuration is left over right or right over left to give us the optimal overlap. These sutures are placed in a horizontal mattress configuration, so we're taking the posterolateralmost portion of the right side and overlapping it to a more superficial or more medial portion of the left side. So the suture goes from outside the right to inside, then from outside the left to inside, then back from the inside aspect of the medial portion of the left suture, and will then ultimately pass the needle back from the inner to outer portion of the lateral aspect of the right side. So in this manner, we're performing kind of a bear hug, if you will, maximally overlapping the sphincter. The repair is usually done with somewhere between 4 and 6 sutures, and I use a PDS suture. I had used Proline, but I found some problems with persistent sinuses and drainage. I had used Vicryl. I think they absorb too quickly, and I've settled on PDS as the material of choice, 2O PDS. So here now we're again overlapping the right over the left, and here'll be another suture on the lateral aspect on the right side, folding the left side back under it. So you can see the way the overlap is proceeding, and you can see once we've placed, in this instance, 5 sutures, we're now tying those sutures in a snug fashion, pulling the muscle together. Ultimately, what we create is a cube of tissue. So we have a dimension that is caudad to cephalad, which is a new high pressure zone. We have a dimension, as is shown here, of anterior to posterior, which are all of the different layers of overlap. And then we have a dimension which we're now looking at, which is how much the left half overlaps the right half. And ideally, we're looking at an overlap of about 3 to 4 centimeters, a high pressure zone of at least 2 to 3 centimeters, and an ano-vaginal separation of at least 4 centimeters. The skin is now reapproximated on its outer aspects, again with Vicryl suture, and I leave the central portion open for drainage. I do not use postoperative bowel confinement. I do not use prolonged antibiotics, just perioperative antibiotics. If the patient has some particular reason, they will also get sent home on metronidazole and ciprofloxacin, but otherwise just perioperative coverage with fiber supplementation and sitz baths. The wound generally heals within 4 to 6 weeks.
Okay, excuse me. So let me close that video. And let me see. I was thinking to show you another one on, let me see where it is. Okay. I was thinking to show you one on sacral neuromodulation because I want to kind of focus on things that are currently available. SNS for fecal incontinence. You know, showing you techniques that are no longer available. I don't think would be terribly useful, like artificial bowel sphincter and injectables. So, and then we can talk about these 2 techniques. So media player, let's show you this one. And hopefully it's optimized. There it is. Okay, so screen sharing. Are you seeing this video?
Yeah,
Sacral nerve
yes,
stimulation for fecal incontinence.
Then we can talk about these 2
The
techniques.
procedure was approved during March 2011 for chronic fecal incontinence in patients who have failed conservative treatment. The typical preoperative evaluation includes history, physical examination, incontinence scoring, physiologic investigation, and if the patient is a candidate, the procedure is undertaken in 2 stages, including a 2-week test stimulation procedure. The first stage is performed with the patient awake but lightly sedated using fluoroscopic guidance. The sacral foramina on both left and right are identified, as are the sacroiliac joints. Using those reference points, a needle is placed into the 3rd sacral foramen from a cephalad approach using approximately a 60-degree angle of approach. First, the area is infiltrated with a local anesthetic, after which the test needle is placed, again, approximately 3 centimeters cephalad to that sacroiliac joint line, along the sacral foramina line at approximately a 60-degree angle. In order to assess for response, the stimulator is used to see if a bellows response can be elicited along with great toe motion and the feeling by the patient in the perineum of a tapping or burning or pain, but some type of sensation in the anus or perineum or vagina. Once adequate placement has been assessed, ideally by both sensory and motor response, then this wire is placed through the stylet needle up until the black mark is reached. It's done under fluoroscopic guidance, and after adequate positioning is undertaken just anterior to the anterior sacral cortex, a small skin incision is made to allow for this introducer and sheath to be placed. Under fluoroscopic guidance, there's a small black bead on that introducer that is placed at approximately the level of the anterior sacral fascia, after which the needle's removed and the quadrupolar electrode is placed, again, under fluoroscopic guidance. Each of the 4 leads is tested in succession, in each case ideally eliciting sensory and motor at the lowest possible voltage. Because it's a mixed nerve, we ideally would like to know that the patient has both sensory and motor response. Once adequate sensory and motor responses have been verified, both a lateral and an AP image are taken for permanent record. In case any subsequent change in function, we can always look for lead displacement. A pocket is made in which the pulse generator will ultimately be placed, but for the moment, the pocket is going to be used for the temporary connector. This tunneling device is used to pass the lead, which is again why we made the small skin nick a little bit earlier in the procedure. The lead is then delivered deep and medial within that pocket, and the small boot is placed over the quadrupolar electrode lead. The electrodes are then placed into the temporary connector. Self-limiting screwdriver is used. Once the click is heard, each screw is sufficiently tightened and there's no need to turn any further. The boot is secured in place with non-absorbable sutures, and a second small tunnel is made, usually going somewhat cephalad, and the temporary connector is then passed through, sometimes with the aid of the initial stylet. Using this stylet guide wire, we can easily pass the temporary pacing wire through and out the skin. A lot of antibiotic irrigation is used, and the wounds are then closed in layers. During the next 2 weeks, the patient will undergo the test phase stimulation, and we aim to find a 50% improvement in the incontinence score, although a reduction in the number of incontinent episodes can also be used. If the patient does succeed and achieves 50% or greater reduction using these variables, then we return to the operating room, open the pocket in which the temporary connector and extension are housed. It's always important to place the electrode at the bottom of that incision, as is obvious here, that we wouldn't like to make the incision down onto the electrode. The extension is removed using the same type of screwdriver. I usually use a laparotomy pad just to ensure that there's no bodily fluids on the electrode. Remove the temporary connector, and then using this interstim 2, the quadrupolar lead and electrodes are placed until there's a small blue mark that is seen all the way inside of that translucent cap. You can see it just to the left of the screen, to the left of my right thumb. The interstim 2 is then placed again with the electrode and the quadrupolar lead under the pulse generator, so that when the incision is subsequently opened, we're not cutting down onto the electrode and lead. After copious antibiotic irrigation, the wound is closed in layers, and temporary programming is undertaken.
Okay, so I think I would probably just want to entertain questions on those 2 videos because it's a lot of information. I have some others, but they're not going to be commercially available. Let me see, let me see if this is a stimulated or non-stimulated gracilis. Let me see. Well, this one is fairly quick. I could show this. Tell you what, let's do this one too. All right, give me a second, and I'm gonna go back here. I'm going to show one very short video on Graciloplasty because that also is something that's available. It doesn't require any expense. So let me show this one. So the patient is in the lithotomy position. What I've done is I've made an incision proximally in the thigh, overlying the neurovascular pedicle of the gracilis muscle. And I'm stimulating the muscle to be sure it's the correct muscle. and to feel the tendon distally, because the second incision is going to be made distally, just proximal to the knee joint, being careful not to cross the knee joint or you can get a flexion contracture. I want to isolate the muscle, and it's notable by seeing the pes anserinus. Those of you who remember from medical school what that is, that the pes anserinus is there, the duck's foot, and that allows me to now have control over the muscle proximally and distally. I then want to put in ethibond sutures distally in the tendon. I put 2 and I divide between them. And the reason I leave a suture distally is in case it's the wrong tendon, which it has been, once out of, I don't know, 400 of these operations. You want to be able to do a tendon repair. So I use a tendon suture called a modification of the Bunnell suture. And then I'm able to harvest the muscle proximally. So here I take the muscle, I divide the tendon. Now there's the neurovascular pedicle, and you can see how the muscle is beautifully contracting, nice thick bulk of muscle. I make 2 incisions around the anus, one on the left and one on the right, and I deepen them through the ischiorectal fat up to the ischial tuberosities, because I want the muscle resting as high as possible here. Up inside, okay? So it's around any viable sphincter muscle. And here we are now, excuse me, once I've made those tunnels, I place sutures in each ischial tuberosity, because I'm not quite sure yet whether the muscle is going to go in an alpha or a gamma or an epsilon configuration. So it's a little bit tough to know how that's going to work. Therefore, I go ahead and put sutures on both sides, have the option of wrapping the muscle in any direction. So here you can see I've got a finger in the anus, and I'm pulling I wouldn't say quite as tight as I can, but very tightly. You want the neosphincter to be snug. You don't want it to erode through, but you want it to be snug. So using those previously placed ischial tuberosity sutures, and those, you can see that's a bone needle. So I go through the periosteum of the ischial tuberosity. And the finished product is there, where the muscle came from up here in the thigh and was tunneled around the anus, and you can see the anus is now closed. So that's the third option that's available. So having shown you the 3 videos, I'm happy to take questions about kind of any of those techniques that are available to us for treatment of fecal incontinence.
Yes, so Dr. Bhalla, Dr. Bagchi, is there any question from the audience?
I've got a question, Professor.
Yes, you
Yes.
can come nearer to the dais, please.
Regarding fecal incontinence, in compare with sacral stimulation and also Graciloplasty, what's the success rate?
Well, okay, so unfortunately I did these a little bit backwards, and last week I gave a 30-minute lecture on the success rates of all the procedures, but just to kind of summarize, for sphincter repair, the short-term success rate that I showed last month was about 85%. The long-term success is under 50%. So typically when I operate on patients, I will tell them if we're going to do a sphincter repair, that they should expect good results for about 10 years, and then they'll probably need something else done. Sacral neuromodulation, the success rate is similar. It's 80 to 90%. But unlike sphincter repair, those results do not seem to wane with time. And we have follow-up results now of 15 years showing no waning of results. People continue to have success in 80 to 90% of cases with sacral neuromodulation. Graciloplasty is different. There's not enough data out there because very few people do the operation. What I would say is it's a very unique operation, which is sometimes the only choice. If the patient had an imperforate anus, there's no sphincter to repair, and sacral neuromodulation may not be effective because there is no muscle whatsoever. patients who've had severe perineal trauma and the sphincter is not reparable may do okay with sacral neuromodulation, but sometimes in combination with Graciloplasty, because Graciloplasty reconstructs anatomy, but it's adynamic and it has no sensory effect. Whereas sacral neuromodulation works by stimulating the pons, the micturition and evacuation center to suppress that urge to evacuate bowel or bladder. So sometimes those two techniques are complementary, but the results are never quite as good. Or rather stimulated Graciloplasty, when we had it available, was an outstanding alternative that had near perfect continence, but only in about 40% of patients, because most of the rest became infected and had to be removed, and that's why we don't do the operation anymore. But the non-stimulated, probably 50 to 60% long-term success.
I've got another question, Professor Mishra, also Dr. Wexner, that regarding rectovaginal fistula, have you come across patient with the Crohn's disease of the rectum causing fistula? Have you come across this sort of problem, and how do you rectify it?
Rectovaginal fistulas in Crohn's disease?
Crohn's, yeah.
Yeah, it's a very, very common problem. There's no question whatsoever. It's something I see in my practice fairly daily with patients coming in, and treatment is really based upon what is the underlying condition of the Crohn's elsewhere. Do they have terminal ileal Crohn's? Do they have rectal Crohn's? The options available tend to be an advancement, a transanal advancement flap, transvaginal advancement flap, a transperineal repair. I tend to favor the transrectal advancement flap. The ones that I tend to see, though, have already had a few failures, and those are patients in whom I would do a gracilis interposition. Not a wrap like I showed for incontinence, but I've shown other videos at Professor Mishra's courses where I just lay the muscle up, separate the anus and the vagina all the way to the anterior peritoneal reflection, and just lay the muscle over the fistula. But all of that is only going to work if the patient has no active rectal disease. So the patient in whom these things work well will typically be somebody with terminal ileal Crohn's who happen to have a postpartum fistula, and not somebody who has multiple branching anal fistulas. The newest treatment for Crohn's anal fistulas, and it's the trial in which I participated from Takeda, which was formerly Tygenix, using stem cells, autologous myoblasts injected around the fistula for people with a maximum of 1 internal and 2 external openings. And although the Admire trial showed us to have about a 60% success rate, give or take, with stem cells, the Admire 2 trial, which was Europe, Israel, and US, unfortunately, it was a negative trial, and it was no better than placebo. Moreover, the placebo success rate was like 45%, which is off the charts, which we don't quite understand. And that may have had to do stem cells, and this is specifically Crohn's, may have had to do with the fact that we closed the internal opening with a figure-of-8 stitch, which is not a generally known therapy for a fistula, but somehow it may have worked in 45% of patients. So we're now doing a trial just looking at closing the internal opening with a figure-of-8 without the stem cells.
Thank you, Professor. Thank you. Anybody?
Thank you.
So there's one question from one of our fellows. Does any of this technique require a fecal diversion in the form of a colostomy or a...
Not sphincter repair, not sacral neuromodulation. Yes, gracilis. That's a good question. Gracilis, you can try without diversion, but the infection rate is fairly high, and I think it's safer to divert the patient before doing a gracilis. Many of these people are already diverted, and now they're trying to get rid of the colostomy, like a patient with severe perineal trauma, or even sometimes imperforate anus. And so it's difficult to judge the success of the operation prior to stoma closure. What I do are two things. One, I'll do a defogram where they come into the hospital, we give them dye, we see how they do holding it. But the other is just ask them at home to take an enema not with any irritant like phosphate, but just tap water, small volume, and see how they do holding it while they walk around or watch television and see how they do. And if they're doing well, then we proceed to close the stoma. If they're still incontinent, then I will often do the contralateral muscle so they've now had a bilateral Graciloplasty. And I think I have a video on that I can dig up maybe for next time.
Thank you, Prof. I think we don't have any more questions.
Thank you, Prof. Thank you very much.
Okay. See you next month. Thank you.
Thank you,
Bye.
thank you, thank you.
Thank you.
Just a second, sir. There's another question from our fellows. If we
Okay.
have a minute. One more
Yeah.
probably we can take. Any of the patients had
Excuse me, sir.
Yes.
Any of your patients had post-operative anal stenosis issues? And my second question is, what is the physiotherapy you have advised your patients post-operatively across the board?
Okay, so number one, anal stenosis is not something that I've seen after either procedure. It is really hard to make a gracilis or a sphincter repair too tight. You're usually dealing with a patchless anus, so I've not seen that. For post-op rehabilitation, I usually just see how patients do in general with the sphincter repair, and if their continence is suboptimal, I will have them start fiber, psyllium fiber, cholestyramine, antidiarrheal agents like loperamide or diphenoxylate. And then I'll supplement that with pelvic floor retraining with biofeedback. But generally, they've got to wait at least 6 or 8 weeks post-op till everything's fully healed before trying. And I honestly think a few more months are better before panicking. The gracilis is interesting because the way the muscle is activated best is when the patient squeezes their knees together. So I tell them, like when you're sitting or lying down, squeeze your knees like you're trying to hold a piece of paper between your knees. Adduct your legs, and that activates the muscle to close it. And they kind of train it by doing that exercise. So that's an interesting one because they kind of can get the anus more closed just by squeezing the knees, which is not what you or I would do, but with somebody with a transposed gracilis, it works.
So all these were 6 weeks post-operatively that was started, sir.
Say again?
The pelvic floor training was started 6 weeks post-operatively, or when exactly?
No. I'm saying the earliest I would ever do it is 6 weeks, but I usually wouldn't do it until the patient has failed standard like fiber, cholestyramine, psyllium, cholestyramine, diphenoxylate, loperamide. If that's not sufficient, I would usually, 6 weeks the earliest if they're really miserable, but that's so seldom the case because with sphincter repair, it's usually that they do very well early and then years later they're not doing well. And then it's no problem starting biofeedback at any time. Probably the earliest I think I've ever sent anyone is about 3 months.
Thank you, sir.
Thank you, Prof.
You're welcome. Okay.
Thanks for nice lecture. So we will see
Okay.
you again next month. Thank you.
Thank you. Look forward. Bye.
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 So questions were less, questions would be more. So I think it is the end of the today program, and tomorrow again we will have robotic day. So we will start again at 9 o'clock. So see you tomorrow. Have a nice evening. Thank you. Thank you very much.